So it is my pleasure to now welcome my colleague, Dr. Keith Kocher, to today's session. Dr. Kocher is the director of the Michigan Emergency Department Improvement Collaborative, or MEDIC, which is one of the Blue Cross CQIs dedicated to improving the quality of emergency care for all. Dr. Kocher will be speaking today on insights that MEDIC has gained through their collaborative quality improvement efforts. He is also a practicing emergency physician, a health services researcher, and associate professor in the departments of emergency medicine and learning health sciences at University of Michigan. So thanks for joining us today, Dr. Kocher, and we look forward to hearing from you.
Yeah, thanks, Mike. It's definitely a pleasure to be here, and just going to emphasize at the end of the day in that introduction, I'm first and foremost an ER doc, and as I was thinking about how to help y'all with the topic for today, I sort of see my role with this talk as providing some contextualization of the emergency department care setting, and in particular some color, adding some color to sort of some of the things that have been brought up earlier here. So few disclosures. I am the medical director for the Michigan Emergency Department Improvement Collaborative, or MEDIC, and then I have a couple other grants, but I don't think they're related to what we're going to be talking about today. So I do think it's worth just setting up a little bit my role in MEDIC and what that project's about as a sort of cousin to Michigan Value Collaborative, and then provide some orientation to the emergency department as a care setting, and then sort of dive into this topic on the table here of readmissions from the emergency department, what the ED can provide as a care setting there. So I've come to see MEDIC as really a change agent. We're here to nudge, to provide activation energy, to shorten the cycle of time between evidence and practice, within this learning collaborative framework that we are living in. We are a growing project still. We're in most health systems at this point. We also have initiatives focused in the care of children, which is unique within the current portfolio. Have about 5 million ED encounters in their registry, 400,000 abstracted cases. And you can see our current quality initiatives, most of it focused in imaging decisions, but a couple in hospitalization decisions. And these aren't the conditions that y'all are focused on, but there's definitely sort of relevance to this conversation based on what we're doing in MEDIC too. So let's talk about the ED. This may be an image that comes to mind when you think about this place. Maybe something like this, and this certainly sometimes happens. Maybe it's more like this. I don't know. I think the challenge of the ED is it's many things. Pulling the old elephant allegory out. I mean, I think it's got multiple missions. It's a rapid diagnostic unit. It's a safety net. It's a cost center for some. It's a critical care unit, admission lounge, standby capacity for disasters, clearly spotlighted with the COVID pandemic. And so the ED is challenged because it has to balance all these missions, sometimes simultaneously. And you have to recognize sort of that context when you approach this care setting. Again, some orientation just at the highest level here. There are about 140 million visits annually across the country. Of course, the pandemic has disrupted that recently. There's definitely some spend. I personally think there is value for that spend, but it's clearly there. Here's probably the most relevant information. I mean, the emergency department really is the source for how you get in the hospital these days. For, I think, most hospitals, it's the majority of the sources for their admissions. And when you think about the pie for unscheduled admissions in particular, it really represents how patients come in. So certainly relevant to this conversation around 30-day episodes. And even probably more relevant, at least as you start to think about the Medicare patient population in particular, as you come in, there's a high likelihood just for the fact that you're being that you're older, that you may get admitted on average. The bottom line, though, for me is, the ED really controls the most consequential routine decision in healthcare. Maybe that's a little bit of outlandish claim, but I think it's got some resonance here. You have to sort of wrestle and understand that. All right, so let's flip this a little bit more and focus on readmissions and how the EDs play a role. The bottom line is they play a role. Here's a selection of literature on this topic. That Health Affairs article is mine. This is looking at various lenses of the problem, conditions, medical conditions, surgical conditions, regions, variation at the facility level, variation at the physician level, within Medicare populations, generally speaking populations. The bottom line is EDs have a role to play. I'm going to spotlight this particular analysis because I think it has some relevance in particular. This just came out 2 years ago. This is looking at Medicare within the context of the hospital readmissions program, or HARP program. And within this analysis, you can see that readmissions have been coming down, but treat and release ED visits have actually been going up simultaneously. Again, spotlighting the fact that EDs have a role to play here. So let's kind of begin to scope out this problem, and have at least sort of the sort of common, I think, building blocks for being to think about solutions. First of all, I think it's really important that you recognize the ED does not select the patients it cares for. We don't control the front door. There is then a selection bias as to who's coming in. And it has implications about what is truly avoidable or not when it comes to a hospitalization or readmission. Clearly, readmission practices vary. I didn't spotlight that in specific with the literature that I showed before, but it's what's been described, and you saw it in the MVC data as well. Hospitalization decisions are complex. Even without the additional challenge from a recent hospital stay. As emergency physicians, emergency providers think about this decision, they're integrating not just the clinical aspects of that care, but factoring in the social context of that patient, the ability to navigate next steps if they were discharged with an outpatient care plan. And you have to realize the complexity here that you're walking into. Certainly, some readmissions are simply unavoidable. And you have to go into this work recognizing that you're not going to drive that down to zero. But there clearly is an opportunity. And it was spotlighted in the presentation from Spectrum Health with Rob and Mike's presentation. So let me set up what I think are some of the ways to think about building out an intervention plan and a process change. So quote from Albert Einstein, if you had an hour to save the world, I'd spend 55 minutes defining the problem, 5 minutes with the solution. Here's one from Edwards Deming. He's a engineer. A lot of people think he is responsible for this plan, do, study, act framing of process improvement, mostly being applied to industry, but ultimately, I think more recently to healthcare settings. If you can't describe what you're doing as a process, you don't know what you're doing. And this is me. I don't know if I've actually said this before, but I'm saying it now. If you leaping the intervention is, I think, frequently why quality fails to improve. All right, so let's think about quality improvement. Solutions are really local, and you got to approach this with the standard things that you would any other process. You really have to go to the place the work is done. So the emergency department, you got to solicit the right stakeholders and make sure that they have ownership of this problem and ask their questions in sort of humble and curious ways. And then you got to design with the end in mind. You know, what's your problem? What's your scope? Which conditions are you going to focus on? What populations maybe you focus on? How are you going to find the measures that are successful? And then you invest. So I'm going to wrap up with what I think are some key considerations, so major fundamentals of how you think about breaking down this problem. You got to think about the ED discharge as a transition of care. It's a transition of care, just like a hospital discharge in many respects. Think about how you resource that hospital discharge and how you're resourcing the ED discharge. I think particularly with the added complexity of a patient coming off a hospitalization, you know, that transition of care can be tricky. You can't expect to rely on the providers to drive this process only. You have to complement their work. I think you heard examples of this with care management, probably social work support. But if your expectation is, I'm just gonna, you know, build a report and show it to providers, you're gonna change, it's unlikely to work. It's gotta function, ideally, 24/7, 365. There's nothing more frustrating to an emergency physician, emergency provider than something that only works, you know, certain days of the week or certain hours of the day. And so the more that you can get round the clock kinds of support, the more likely you're going to get the traction that you want. And ultimately, you got to address the fundamental needs of both the provider and the patients and families. They got to feel like there is safety in the decision to discharge, that the baton is being passed in a way that will be picked up on the other end of that discharge. And if you're not addressing like those fundamental concerns, again, you're not going to get the kind of traction that you need. So a bit of a whirlwind. I'd love to hear any sort of questions or comments, respond to those. Certainly I got a lot of contact information here about both the MEDIC project, and certainly you can reach out to me as well. But hopefully that'll provide some of the context you guys need as you move forward.
Great. Thank you so much. I certainly am, pleased that MVC and MEDIC has had a kind of ongoing collaboration. Look forward to many more ways for us to collaborate, especially around this topic. Mark, do we have specific questions?
Yeah, the first question that's come in, Dr. Kocher, is probably a pretty timely one, given that we're all living through the current pandemic. There's a question as to what scope there is for continued use of telehealth initiatives to help relieve ED utilization. I don't know if you've seen any changes over the last year or any insight you can offer on that.
I think we all recognize telehealth has a huge opportunity. Really got a sort of kick from the response that we had to provide as a result of the pandemic. There are a ton of use cases for telehealth, generally speaking, in the space of unscheduled acute care. Whether you're talking about the use case of sort of on-demand, sort of prior to ED visit, sort of at the point where patients are trying to determine, what's the best care setting to get help from. There are use cases of patients in emergency departments as well, to decompress waiting rooms, for example, to provide consultative referral kinds of services for outlying centers, for example. So there's like a ton of experimentation that's going on and a ton of opportunities. We can get into specifics if you want, but that's sort of my perspective on it.
That's really helpful. And I suppose if we just take it a step back, looking at the next question that's come up in the Q&A, I know we talked about that some readmissions are completely unavoidable. But, you know, stepping away from that, what would you believe is the biggest reason that patients often use the ED rather than urgent care or seeing their PCP?
It's an important question. I've come to believe that I think it's unfair to patients to describe their ED use as inappropriate. I think they are being human when they choose to get care. And I think what you need to fundamentally respond to is that need. If they think they have a problem, let's build a system that allows them to get the care that they need to address that problem. I have no problem that being a lower cost center, primary care, urgent care, sure. But let's help the patients navigate the system in a way that allows them to arrive at that lower cost center potentially, and get the care that they need. So I think at the end of the day, people are just reacting as you would as a patient. You know, I'm scared, I'm hurt, I'm not sure what's going on, I have symptoms, help me. And we need to sort of meet them where they are on that.
Just one final question. You had a nice bullet on one of your slides about approaching the Gemba. How do you recommend hospital leaders approach that?
It's probably a good question for Rob Nolan and Mike Getty, you know, because they did it. I mean, you have to have like clinical champions. So who is, you know, your ED leads, and invite them into that conversation. Ask them for a tour of the emergency department. Let me understand your workflows. Let me understand your care setting. Show me a day that is where your weight room is, you know, 20. And help me understand sort of what you're up against. I think it's at that level that you need to interact. And then as you begin to sort of understand, build the relationship, then you can figure out, you know, what's going to work best for you locally.
Well, thanks, Dr. Kocher. Back to you, Mike.
Great. Thanks, Mark. Well, Dr. Kocher, thank you so much for joining. And again, we look forward to more collaborations. And hopefully if there's questions come up, we will direct them your way and to Medic as well. So thank you again for joining us.
Thank you.